Hello, everybody. Thank you for joining us for Med School Tutors Fetal Heart Rate Tracing webinar this evening. Our goal is going to be to teach you guys anything and everything you guys need to know for the ObGyn shelf and Step 2 CK when it comes to fetal heart rate tracing. My name is Dr. Hansen, and I'm here as a tutor for MST. I've worked with the company for over 4 years as an individual tutor for everything from basic biochemistry up through Step 2 CS. I've spent over 5,000 hours working with students online for board exams, worked with over 300 individual students, and I'm going to use that as my bona fides tonight to kind of help you guys get to where you need to go when it comes to learning about this stuff. I'm joined by Dr. Sam. You want to introduce yourself, give your background a little bit?
Thanks, Joe. So pleasure, everybody. My name is Hassan Mahmoud, but please call me Sam. It's been my nickname. Took out the first 2 letters. That was my first accomplishment as a future doctor. And I come from St. George's University, where I started teaching from that point in my second year as a second-year student. And I've been with MST for the past 3 years, almost coming up 4 years. Haven't had as many hours as Joe, but I've had the privilege of meeting a lot of people throughout the United States, tutoring from Step 1 to Step 3 and Step 2 CS, as well as residency, consulting, and advising. I love listening to everybody's stories and getting to know all of you, so I'm really excited. So thank you.
All right, so let's go ahead and jump into it. Before we get started with the actual material, let's talk about our game plan for this evening. So we'll tell you guys a little bit more about who MST is and who we are and why we're here talking to you this evening. And then we'll dive into talking about fetal heart tracings and some general tips for preparing for the ObGyn shelf exams, Step 2 CK and Level 2 CE. And then at the very end of the conversation this evening, we'll do some question and answer. If anybody has any specific academic questions about anything related to ObGyn, or alternatively, any questions about anything we bring up this evening that doesn't quite make sense, feel free to shoot us a question in the chat box and we'll do our best to respond. You guys can actually type to us during the conversation this evening, and we're going to encourage you guys to do so. You might notice myself or Dr. Sam looking over to the side here as we type into the chat box, which should pop up with a message from me right now. So I apologize, it looks like my attention is wandering from time to time. But if you guys have any questions as we're going through the material, please feel free to pop them towards us. We'll do our best to incorporate them into what we're discussing. In addition to that, if you guys want to provide some answers to questions we ask you, we're going to ask you guys to be as interactive as possible this evening, and we might ask you some questions about some images or diagrams we put up after we teach you the basics here. So just to tell you guys a little bit more about ourselves before we move on to the ObGyn material. Med School Tutors is a one-to-one online tutoring company. We tutor from everything from pre-med all the way up through residency and board exams taken during residency. So medical school and everything surrounding, essentially. We've been in business for over 15 years, working with hundreds and thousands of students. And we've got a ton of medical students, residents, and even some attendings now that are experts in their individual fields and towards the board exams. We all love to teach quite a bit. Obviously, I've spent thousands of hours doing it, so I must like it. And so if you guys are potentially interested in pairing with an individual tutor that could help you towards anything surrounding medical school, maybe give us a look. We'll keep our communication information on the bottom of the slide here if you guys want to take a look at our website or anything like that along those lines this evening. So without further ado, let's get into what we're actually here to talk about with fetal heart tracings. So Sam, you want to take us through just like the basics? Why are we looking at this stuff?
Sure. Thank you, Joe. So fetal heart tracings, ObGyn, I'm sure you guys have heard a lot of things, and you know that OBs and GYN is kind of like one of the more difficult subjects in Step 2. And I think it's all about having a good foundation of knowledge, especially when it comes to fetal heart tracing. Step 2 CK loves to ask about ObGyn questions because the guidelines are very kind of systematic, and there's a specific approach that you need to have to really master these questions. So going over fetal heart tracing. So we have basically 2 type of monitoring devices that a woman has, and closer towards the end of their stage of labor or going into labor, that we're monitoring the fetus. So there's a tocodynameter as well as a telemetry monitoring device. So the tocodynameter is a device that measures the compression capability of the actual uterus, the tone itself of the uterus. And that actually provides us a lot of information, which we're going to go over in the coming slides. The other thing we want to do is we want to look at the actual fetal heart rate itself. And the fetal heart rate transducer, as you can see in this animation, is right below the tocodynameter. So those 2 pieces of information are going to help you understand what's going on with the baby as well as the mother too. And we have some really interesting examples coming up. And I know that Joe's going to go over kind of the basics as to how we see it on a actual strip. I'm sure you guys have seen on your ObGyn rotations, or you will soon, and how we interpret it. Thank you.
Yeah, just to jump into those basics, kind of give you guys the basic language that we're going to need to understand everything from the ground up here, describing the tocodynameter that Dr. Sam was mentioning here is on the bottom part of this graph that's measuring the actual pressure that the uterus is exerting. And so you can see individual discrete peaks in many cases when you have a woman that's presenting in labor who has regular contractions. And that's to be compared to the image on the top, which is the telemetry monitoring of the actual fetal heart rate. Now, these are virtually always paired together. You want to be seeing both the contractions and the fetal heart rate simultaneously because there are interactions between these two things that we'll talk about later, like decelerations, that require you to have both pieces of information to adequately diagnose what's going on with both the fetus and with the mother. One key thing to point out here that's fairly well highlighted in a lot of the images that we'll use this evening, the normal fetal heart rate is between 110 and 160, so nearly double the adult heart rate, give or take. And so this blue band that we have in this image is giving us like the nice normal range we're looking for. Sadly, you likely won't have that blue band on your actual questions if you're to take these on the exam. So that's something that we'll need to memorize and have a general idea of, because sometimes they're going to give you a very fast heart rate that you have to interpret based on the numbers arrayed on the y-axis alone. Kind of like bouncing away from that a little bit, when we talk about the baseline fetal heart rate, like we said, we're expecting somewhere around 110 to 160. Generally speaking, tachycardia is going to be anything over 160, and bradycardia is going to be anything under 110. The basic idea that we're looking for here, though, is that the fetal heart rate has to be either tachycardic or bradycardic for a pretty good amount of time. For tachycardia in particular, we need 10 minutes of the heart rate being above the upper limit of normal. And for bradycardia, we usually want it to be below the lower limit of normal for a little bit less time. We're going to be a little bit more sensitive to that, which is going to be around 3 minutes as our cutoff. Each individual red line on this graph, each vertical red line, is representing 1 minute of duration, which means in order to have fetal tachycardia, this heart rate would have to be high for the entirety of the graph, more or less. The reason we're doing this is because there is going to be natural variation that we should expect with the fetal heart rate, which is called variability. So Sam, you want to kind of talk us through like what is variability? What are we looking for there?
Sure, Joe. So variability is our way of really looking at how the health is of the fetus or the baby overall, as well as the mother too in relation to that. So we have 3 different types of variability. The first one is absent variability, as you can see in the top right illustration. And I don't know if anyone can help me out, but is that something to be concerned about? If so, give us a comment or feel free to chime in. I'll give it a couple of seconds and then we'll talk about it. Okay, Akshata, that's a very excellent point. Okay. Very excellent answers I'm seeing. So talking about absent variability, so Akshata brings up an excellent point that absent variability has to be in the sense of clinical context, you need to use it. So if you see a scenario in step 2 CK is all about understanding the scenario at hand with respect to the patient, the mother's vitals and the baby's, the tracing that's going on. But absent variability sometimes could be something as simple as the sleep cycle. There's times between about anywhere from 30 to 90 minutes that a baby is actually undergoing a sleep cycle and their heart rate is actually not that variable. But in a different clinical context, you could see that absent variability can be a harbinger for more worrisome things that can go on that we're going to be talking about in a second. So that's how you can distinguish the two, and that was an excellent point. Moderate variability is, as it says on the slide, the amplitude range in terms of the change from the heart rate can range from anywhere from 6 to 25 beats per minute, and marked is greater than 25 beats per minute. So in absent variability, 2 things you need to think about. Sleep cycle, read the clinical vignette in the context of it. If there's no distress in the mother's part, no fever, no tachycardia on her end, no concerns of sepsis, then think about that. If the baby, if she's febrile or there's a sign of risk factors for infection or a risk factor for the placenta to be compromised, me more concerned that absent variability means something that the baby's actually in distress. Joe, do you think I missed anything, or how was that?
No, extremely well said. I'll simply point out that if we were to look at these graphs and say, not pay attention to variability, it'd be kind of easy to say, well, maybe this is tachycardia because we're spiking over this line for just a moment. But that's why we have the diagnosis of fetal tachycardia as being 10 full minutes of a fast heart rate, because even with moderate variability, you can see some spikes that might bump up against the upper limit of normal there. Awesome. So great job talking through that. Let's go ahead and talk about another key feature that we need to pay attention to that would interfere with the diagnosis of having some kind of tachycardia, and that's an acceleration. So a fetal acceleration is defined by 15s. The number 15 is really important here. It's 15 beats per minute above the baseline for at least 15 seconds in duration. And so you can see here that we have this big uptick in heart rate that lasts for nearly a full minute, if not a minute and a half here on our current fetal heart rate, which is going to be normal as far as a acceleration is concerned, and not actually fetal tachycardia. Not long enough to be fetal tachycardia, but also too long and too substantial to be considered a portion of the variability that we would end up seeing here. Now, generally speaking, accelerations are to be expected and in fact are a reassuring finding, one that would be a good thing perhaps, especially if you're doing some kind of screening procedure for a third trimester woman who's coming in. You can end up doing a non-stress test where you look at the fetal heart rate and your explicit goal and purpose is to find accelerations. So this is a bit of a trickier question, so I'm going to give you guys a tough one. If anybody can type into the chat, what counts as a reactive non-stress test when you have a woman coming into clinic and you're measuring her fetal heart rate? So non-stress test, reactivity. Can anybody answer me that?
That's
It's a little bit longer. It's longer than one word, so it's going to be harder for people to answer. Okay, so got a couple of answers here. So far I have has accelerations, accelerations. A couple more people saying that. That is correct. Has accelerations is required. We need at least 2 accelerations in the span of 20 minutes is usually going to be the goal that we're looking for fetal accelerations. Now, like we mentioned with the absent variability before, you won't really see accelerations in a sleeping baby. So here's my follow-up question. If we don't see accelerations and we presume the baby might be asleep, what would you do next if you think the baby's sleeping and you want to see what the baby looks like when they're not sleeping? So go ahead and type into chat what you would do if you had a non-reactive, non-stress test and you wanted to see that. All right, I got 1, 2 answers. Let's see if we can't get another one. How do we get the baby? Okay, there we go. So I got a couple good answers here, and one of them being that we can try to wake the baby up. And that's basically it. This is where we would use something called vibroacoustic stimulation. You basically place a cell phone against the woman's abdomen and give it a call. That way you get noise and vibration that wakes the baby up. They might be a little bit cranky, but if they've got normal healthy status, we might see some accelerations, which we want to see. So accelerations, desirable, and also a feature of an appropriate and good reactive non-stress test. Anything else to add about like accelerations or variability, the good stuff, Sam?
No, I think that was excellent. I think accelerations as take-home point is a good thing. You have to recognize that accelerations are signs of reactivity that we need to see in the baby. And that, again, in clinical context, if there's something concerning, always proceed with the next best step, which is that acoustic stimulation that Joe was saying.
Awesome. All right. So moving on from looking at the actual rate, maybe we can talk a little bit about the actual tachometer too. So Sam, talk to us about what we're looking at the bottom part of this graph.
So in the bottom part of the graph, you could see that there is oscillations up and down that are measuring, as you could see in columns with how they have the y-axis of 175, 50, and 25. You could see that the correlation of the line is basically something called a Montevideo unit, which measures, thank you, Joe, the contraction strength of the baby, of the uterus itself with respect to the fetal heart tracing above. So in real time, the peak of that contraction correlates at that same time with the heart rate directly above. It's a real-time strip, and you can actually obtain, as we started already alluding to, a lot of information from that. Step 2, a CK is not going to ask you to average it out. It's not going to ask you to really give specific numbers. You need to understand that that is just signifying contraction, and you got to look at the fetal heart tracing.
Awesome. So one thing I'm going to emphasize too, to bounce off your idea of what step 2 CK might do, here is a really mean thing step 2 might do if they were asking you about Montevideo units. Sometimes they will ask you to assess whether or not the strength of contraction is adequate during active labor. And that's where these guys come into play. They allow us to determine whether or not the woman is more or less pushing hard enough with the uterus. However, it's very rare that they'll actually give you a graph like we're seeing here, like Dr. Sam mentioned. Instead, what they like to do is say, well, we have contractions every 3 minutes,
Yeah.
and they're about 50 for their strength in terms of millimeters of mercury, 50 Montevideo units. It's very tempting to say, well, if I have a contraction every 3 minutes and I'm looking at 10 minutes duration to measure the actual Montevideo units, then that's probably 3 contractions. Incorrect, because they will measure the first contraction at minute 0, which means minute 3 is contraction number 2, minute 6 is contraction number 3, minute 9 is contraction number 4. So if you were to measure Montevideo units here, and we're counting the Montevideo units as being like, let's say 50 per peak in our example, it's not 3 contractions in 10 minutes, it's 4 contractions in 10 minutes. If they say Q3 contractions, the first contraction starts our measurement of the 10-minute process. Now that becomes important because when we are calculating Montevideo units, we want to have more than 200. That's the number to know. You have to have a Montevideo unit count of more than 200. The peak pressure of every wave over 10 minutes has to add up to a number greater than that. If it doesn't add up to a number greater than that, we do not have adequate contractions. And basically, mom isn't pushing hard enough. Not to blame her. She's not putting in enough effort per se, but the uterus isn't contracting hard enough. So somebody's already getting ahead of me, but maybe I need a couple more people to answer. What would you give to a woman if the uterus is not contracting hard enough? What's the agent we can use to improve contractions?
Some good answers.
Yeah, all right. I see a couple different ones that usually end in osin. So pitocin, oxytocin, these are all excellent answers because these are going to be the things that actually increase contraction of the uterus. So you can give exogenous oxytocin or pitocin in order to increase the pushing that the mother is doing. So that's kind of the thrust of the questions they're going to be asking when they're looking at the actual contractions themselves. All right, so Montevideo units, kind of an ambiguous thing. We want them to be above a certain number, but we know the woman's going to have contractions. Accelerations and moderate variability were good things that we were looking for to assess that the baby's healthy and safe. Now we have to kind of talk about decelerations a little bit, which is when the heart rate is going to slow down. So 3 different types of decelerations. Sam, you want to take us through our first one here, which are the early decelerations?
Right. So 3 decelerations. The first one we want to talk about is an early deceleration. You could see that at the beginning of the contraction with respect to tocodynameter, you could see that the drop in the heart rate. And that is the key to distinguish between an early deceleration and a late deceleration. Having your ability to see when the beginning of the contraction begins and then looking at when the heart rate starts to drop is super important. You can see that the first 2 arrows are correlating each other with respect to the tocodynameter and as well as the fetal heart tracing. And that's your way of saying that this is truly an early deceleration. So what does an early deceleration mean? An early deceleration is usually during the labor process that occurs with respect to the fetus having compression of the actual head itself. Fetal compression of the head actually causes a reflex type of vasovagal event, not vaso, I apologize, a vagal event with respect to the baby's heart rate, and that causes a little bit of a drop. Sometimes step 2 can ask questions as to what further steps are needed. And really, this is a reassuring type of fetal heart tracing that means that this is the active phase of labor and the baby's head's being compressed. It's usually that the progression of labor will continue and there's nothing to be concerned about. Joe, anything else you want to add on this slide?
No, excellently said. I guess I'll just add to my little personal interpretation of what is going on here. When the baby's head's being smashed, I kind of like to think of it like the brain is interpreting this as being a massive amount of pressure, but specifically blood pressure. So the brain only knows I've got a lot of pressure. I better tell the heart to chill out. Well, the heart's not really doing anything abusive or wrong here. This is external compression of the head, but there's no means by which the baby's brain can know that. Keeping in mind that fetuses have very soft heads. They don't have closed calvaria yet. And so the increase in intracranial pressure, it can only be read from the adult standpoint as an increase in pressure coming up from the heart, an increase in blood pressure. So the brain says, let's just turn down the heart. Let's make it beat less hard. That should resolve the pressure that we're experiencing here. Of course, that doesn't do anything to influence the pressure, and the early deceleration naturally is going to kind of fade away as the contraction fades away. So two ways to kind of assess this. The way that we've got labeled here is that the beginning of the decelerations begin together, or the beginning of the deceleration begins with the beginning of the contraction. But I have a more preferred way of looking at this, and it's that the peak of the deceleration should kiss the peak of the contraction. There should be direct lineage here between the peak and the trough, essentially, at the same time. So if you have a perfect mirror image in the shape, that's more or less going to end up being an early deceleration when we see it. Now, the reason we're emphasizing so much the relationship between the contraction and the deceleration here is because we also have late decelerations. And late decelerations absolutely do not line up peak to peak in the same way that we're seeing here. Usually late decelerations only begin when we get to the peak pressure of the uterus here. And so when we're looking at a late deceleration, very much unlike the early deceleration, here we're a little concerned, we're a little scared. Generally speaking, this represents the fact that the fetus is not receiving adequate perfusion. And so the term we use for this that's really fancy is uteroplacental insufficiency. Not enough blood getting to baby, which can be an emergency, and if prolonged, might require you to actually go in and cancel the normal spontaneous vaginal delivery and transition over to cesarean section. I kind of like to think of this situation as the contractions themselves kind of wringing out the uterus and placenta, kind of draining the blood from it through direct pressure, which means that during the contraction, no additional blood is really getting in and making it to the baby. And so as a result, we got to get that baby out of there very quick, because there's not really going to be any direct intervention that we can do otherwise that can increase perfusion to the baby. Sam, anything to add to that about the late decels here?
No, that was an excellent summary. And I think that some intrauterine resuscitation techniques that you may see on step 2CK can include amnioinfusion that can help increase effective circulating volume for the fetus, that can help with these late decelerations. But as Joe was saying, really, there's now the time is on the clock in terms of getting this baby out, because this is really kind of a very concerning sign.
Absolutely. Now, one more deceleration left. Sam, you want to take us through it?
Yeah, sure. So the last deceleration to discuss are variable decelerations. As it is indicated, they're variable in onset in nature in terms of when they relate to the contraction, uterine contraction, and fetal heart tracing. You could see that it dips pretty almost like a V shape. And I actually think about variable decelerations, if the V kind of looks like almost like, you know, kind of constricting on the neck. That's the way I look at it. And if you were to place a baby's neck in between that V, it's kind of like a sign of cord compression that's wrapping around the baby. It always stuck with me, and it really, really allowed me to answer this question as well on step 2. Variable decelerations, think of umbilical cord compression or prolapse. So it's basically causing decreased perfusion to the fetus. Anything else, Joe?
I think I would add only that one thing that we don't have noted on our slide here is that if we have a baby with umbilical cord compression, there's some pretty conservative measures that you can do that can help to resolve the variable decelerations. And that would be maybe to reposition the mother and kind of put her in the left lateral decubitus position, or maybe some more aggressive repositioning of the mother in order to try to get the baby to kind of fall off of the cord if gravity is pushing the baby onto the cord. Alternatively, this is where an amniotic infusion can also be really useful here in order to kind of like push some fluid into the uterus and give the baby some buoyancy to kind of come off the cord in that case. That being said, we don't really worry about these ones as much, generally speaking, unless more than half of the actual contractions are leading to variable decels. We usually just kind of ignore it. It's not really necessarily going to lead to hyperperfusion of the baby unless it's happening very consistently, at which point we'll get more and more aggressive with our interventions, perhaps even moving towards the cesarean section in this case if we have lots and lots of variable decelerations that we cannot resolve. So if we add all these guys up, there's a kind of nice mnemonic that we can end up using to help remember these, and that's veal chop. The idea here is that you arrange the veal vertically, VEAL, for variable early accelerations and late decelerations. And then you align CHOP next to that, where C stands for cord compression. So variable and cord compression have now lined up on our two vertical pathways here. So we have veal chop, and then V lines up with cord compression. It's a little bit of a weird mnemonic, to be honest. You really have to have a graphical interface here to make it work the best. I do think it's kind of funny that accelerations are on here at all, insofar as it's just okay for accelerations. So those are good, those are benign. Like we said before, in fact, we're eagerly searching for those in many cases when we're doing a non-stress test in a woman who's coming into clinic. So this might help to kind of organize which ones we care about. And in reality, the ones that we care about most are the late decelerations. The rest of these findings can range from benign to innocuous to potentially dangerous, but the late decels are the only ones that require an immediate intervention in many cases. All right, so I think we've kind of gone through like a lot of the language that we need to utilize in order to interpret these things. We talked about how we read the Tocodynameter. We've talked about how we have kind of a normal heart rate that we're looking for, not tachycardic, not bradycardic. We've also looked at variability, accelerations, decelerations, also counting Montevideo units. With that language under our belt now, we more or less have the tools that are required in order to dive into looking at real examples of these things. So Sam, I'm going to kick it off to you to go ahead and give us our first example here and walk us through what we might be seeing.
Thank you, Joe. So this example is very interesting because I think that, on step 2CK, you may not see your classic, the variable early or late deceleration. You may see something as simple as this. And this is very important to use clinical context with respect to the vignette. So for example, if it was a 35-year-old woman, she was 38 weeks and now in labor, comes into the L&D unit and is febrile to 101, had a WBC of about 13,000, and was in the active phase of labor, and the fetal heart tracing and Tocodynameter showed the following. Who here can tell me what they think of in terms of the fetal heart tracing? What is concerning? Okay, excellent. So Mario Mikel said fetal tachycardia, and that was right on the money. That was very fast, and I love that. So that's correct. So as we looked at, and remember that little highlighting part that's kind of indicative the normal heart rate's not going to be there, as Joe was saying in the beginning. But you can clearly see that in the fetal heart tracing, it's about 175, 180 beats per minute, which is not normal. And you could see that with the context of the vignette, that the baby is in distress. And some differentials that you can think about with respect to the distress of the baby is the baby simply tachycardic because of the sepsis of the mother, or is there something more commonly tested on step 2CK, such as intra-amniotic infection or chorioamnionitis? That's what it used to be called. So fetal tachycardia, something to always be concerned about. Use the clinical context of the vignette and come up with your differentials.
All right, they answered your question too easy, so I'm going to give them a hard one here.
Yeah.
Chorioamnionitis most commonly is going to be seen with prolonged rupture of membranes. You get a direct pathway into the uterus, and therefore you'll get an infection of the amniotic tissue when the membranes rupture. So once the water breaks, you have a limited amount of time, usually less than around 18 to 24 hours, to deliver the baby without increasing the risk of developing an infection here. However, there is at least one blood-borne infection, blood-borne mechanism to cause chorioamnionitis. Now, let me preface this by saying I'm not saying a Torch's infection. I'm not saying an infection that is necessarily transplacental that affects the baby. I'm looking for one bacteria that infects the amniotic tissue specifically, causing chorioamnionitis in a woman who's not in labor. Can anybody give me that answer?
I love that.
It's a favorite on the test.
Yeah, that's a good one.
Think about it.
Ooh,
all right. Okay, so I'm going to say the answer that I'm seeing most commonly, and then I'm going to see the answer that's correct. So I'm seeing a lot of people say GBS, group B strep. That is going to be an infection that happens when the baby crosses the birth canal, right? So that's an intrapartum infection during labor and delivery. I'm saying an infection that reaches the amniotic tissue before labor even starts with intact membranes. And we have at least, oh, there we go, two good answers. So Shreya, good answer, and Wayne, good answer. Listeria. Listeria can actually cause chorioamnionitis and cause this fetal heart tracing when the mom presents. Listeria might be fairly innocuous in the pregnant mother, not good for the baby though, and the chorioamnionitis that manifests will lead to this fetal heart tracing and probably a tender kind of abdomen uterus picture. Generally speaking, this is why we will recommend that pregnant women avoid any kind of cold cuts, refrigerated foods in the grocery store, refrigerated meats and deli meats in particular, because listeria can proliferate in cold temperatures. Not that you should anticipate listerias around every corner in the grocery store right now, but if there were an outbreak, let a young, healthy male get infected and develop listeria, not a pregnant woman. And so the idea is that we want to protect women from the possibility of difficulty with childbirth or damage to the baby by telling them to avoid these things altogether, just in case they happen to be the index case for an outbreak of listeria.
Joe,
Right,
can we take it one more step? And step two may ask this question. How would you treat, what antibiotic would you use in this situation? And I know this is tough, but this could be a third or fourth order question. Okay. So Wayne Broth has given us, he said ampicillin. Okay. Valerie, ampicillin.
All right. Excellent answers, guys.
Good. So usually you'll see ampicillin, but usually the combination ampicillin and gentamicin. They usually like to have that combination to cover for listeria and other gram-negative bacteria. And as Joe was saying, through the birth canal, that's what they're at risk for, is that those gram-negative species as well as listeria. Excellent job.
All right, let's close that loop fully before we move on to our next one. This is why, if you have a neonate presenting with a fever and you identify or suspect that they have meningitis, neonatal meningitis empiric therapy must include ampicillin. Unlike a 5-year-old kid coming in where you give them maybe like ceftriaxone or something like that as their kind of empiric antibiotic therapy, you must also include ampicillin in the empiric antibiotic therapy for a baby coming in that's less than 30 days old that has some kind of meningitis. So empiric therapy for neonatal meningitis includes ampicillin. All right, guys, great job answering this. We asked some hard ones there and you guys kept up with it. So let's go ahead and bounce over to our next example tracing here. Now, what I'm going to point out with this one is that we can see that the line is firmly within the blue territory this time. It's not above it, so it's not that easy. And in addition to that, if we look at the kind of pressure monitor down below, there is a uterine contraction here, but I'm not really seeing any relationship between the uterine contraction and the line that we're looking at. So can anybody tell me what is noticeable about this fetal heart tracing that seems firmly planted in the normal range? Okay, I see somebody saying what is happening potentially here. So I'm gonna kind of give some credit to Jotan here. This is potentially a fetal sleep cycle. What did we say earlier about fetal sleep cycles? What would I say about the variability of this heart rate, given that we think the baby might be asleep? There we go, there's the answers. So we have absent variability now. So the fact that we don't see really any bumping up and down is something we should pay attention to for fetal heart rate. We should expect a little bit of up and down bumping for the fetal heart rate as we're kind of progressing over the course of, in this case, several minutes, but usually 10 minutes. So if the baby's asleep then, and here's kind of like your wake up call to the students here, what was the thing we would do to wake the baby up if we wanted to? I said it once early in our conversation.
I like that pause.
Yeah, it's a good answer. All right, I've got everything from buzz to acoustic to vibroacoustic to vibrations. Vibroacoustic stimulation is the full term. Basically, yes, you zap the baby, put a cell phone against the abdomen of the pregnant woman and give it a call, and that should wake the baby up. Now, we're not necessarily going to do that while the woman is in labor per se, but this woman who has maybe perhaps one Braxton Hicks contraction here is likely coming into your clinic for an antenatal checkup, and you're going to do a fetal non-stress test in order to assess the safety and well-being of the baby. And in that case, you would need to see if the baby has accelerations, and you can't see those if the baby's asleep. And so this is where we might wake that baby up. All right, anything to add, Sam, before we move to our next example here?
No, that was excellent.
Cool. All right, I'll kick it off to you.
Great. So this one is something that we kind of spoke about briefly, and I think it's another kind of not the classic fetal heart tracing, and we have to use some clinical context as well. But I'm going to make this a little bit more difficult. So I'm going to ask them questions first. What's concerning in the actual fetal heart tracing? So leave it up to everybody to give me some answers here. Excellent. Wayne Broth, excellent. Bradycardia. Matthew So, bradycardia. Good. Excellent. So I have some people saying core compression already. Excellent. So that's correct. So this is fetal bradycardia, and you could see that below that highlighted segment of the normal heart rate, and that's not going to be there obviously on the real exam, but you could see that it's well below it. Okay. So I'm going to make this even a little bit more challenging now and give you a clinical vignette scenario. A 38-year-old woman gives birth to this baby who there was no complications, but this was on the fetal heart tracing. The baby has an interesting rash on the face and has now stayed in a complete heart block in terms of the baby's EKG reading. What? Oh, wow. Wayne Broth, that was fast. Okay, so that is correct, neonatal lupus. So sometimes you can actually, this is a very rare scenario, but congenital heart block secondary to SLE can cause bradycardia, sustained fetal bradycardia. What are some other more common causes of fetal bradycardia? I'll leave it to everybody. And yeah, you got the antibodies right. Wow, good job. It's anti-SSA and anti-SSB, Rowe and Law. What are some more common? Okay, hypothyroidism, Mario Mikel. What else? Good, hypoxia, excellent. So hypoxemia, that can cause bradycardia, excellent. Fetal hypoxia again, Mario, good job, Exasa, good job. And core compression. So core compression is you'll see more of the variable deceleration that's going to be tested on step 2, but that could be on your differential if you see fetal bradycardia. Joe, anything else we should add on this?
No, I think we nailed it. An excellent job to the students for putting some excellent answers to your questions here. So they're going above and beyond, not just answering what we're seeing on there. Yeah. All right. Well, I'm going to make things harder here. I'm going to bring up our next image here, and I'm going to ask, what do students see with this one? So no training wheels on this one. Just type into chat what you think is happening with this tracing, with the contractions that we're seeing here. How would you diagnose this one? I've got an answer that's getting close, asking about the possibility of seeing a decel here. So yes, this is deceleration that we're seeing in this case. Seeing a couple people say some things here in the chat, and to be honest, this one's a little bit difficult to appreciate, so I'm going to try to help us out as much as possible. We see a contraction that's right here, and we see a contraction that's right here, and we're seeing that with this contraction, there does seem to be a mild decrease, but not really 15 beats per minute. And here we do see a drop of at least 15 beats per minute. Now the problem is there's some variability that junks this up, but if we line these guys up, this looks like it could end up being an early decel that we have in this case. Maybe there's another one over here, perhaps, but this is a very messy baseline that we have in this case. This example is not so much a board exam ready example, and more of what you might see actually on the clinical wards. And so you should be prepared that when you're pimped by an attending that asks you, what do you see on this tracing? Sometimes you really have to read the kind of like constellation here and kind of make up a shape that you're seeing in this case. So this is an example of a early decel in this case, which you kind of have to squint to see, I know, but you have to be prepared for this on the clinical wards. In reality, on the exam, they will never give you anything that's this ambiguous. So I'll ask you a fair question now, everybody. What is causing an early decel when it's happening? I see one good answer already. All right, Mario, Matthew, you guys got it?
Nice. This is making me happy.
Yeah. All right. Cool. All right. So we got at least 3 people saying we got head compression. Now, I want to be careful here. This is not necessarily going to be umbilical cord compression, because remember, that would give us more of a variable decel picture.
Right.
Head compression, though, that increased intracranial pressure will lead to a vagal response and parasympathetic output that will end up slowing down the baby heart. So in the same way that neonatal lupus with heart block of the AV node is going to cause slowing of the heart rate, vagal inputs to the AV node temporarily during head compression will slow the heart rate as well. So there's a small connection between those two. All right. Anything to add to this one, Sam?
No, that was excellent.
All right. Good job struggling through that one with me, guys. I know that was a bit of a tough example. Sam, I'll kick it off to you for this one.
All right. So again, no more training wheels. I think we should go ahead and think about what we're seeing with respect to the heart tracing and look at the contraction. Remember, we showed a connection, and if you could see it and come up, always have this kind of approach at looking at the peaks, and when beginning the heart tracing, that dip begins, I think you can really, okay, we're seeing already some causes. What is the example? What is this heart tracing? Good. I'm starting to see. Okay, Matthew, Mario, good job. Late decelerations, uteroplacental insufficiency. Okay, Matthew, so hypoxia. Excellent. So you guys are already jumping the gun, but yeah, so it's late decelerations that are occurring. And the first thing you got to think about when you see late deceleration, uteroplacental insufficiency. So again, look at the peak of the contraction. And Joe will point it out for us. The peak of the contraction correlates with the beginning of that nadir for the heart tracing, the deceleration, okay? Always look at that, and you'll have that nice systematic approach to say, bam, this is late deceleration. I got to think about uteroplacental insufficiency. Some people were already actually going beyond uteroplacental insufficiency to actually tell us what are some causes that lead to placental insufficiency. Some big ones, maternal hypotension. Another big one that they like to test on step 2 is placental abruption. Placental abruption, barely high yield to no. Abdominal pain, these type of decelerations that are occurring in a woman that's in labor, you got to think about placental abruption. Joe, anything else?
No, you nailed it completely. Just want to keep in mind that the late decelerations is the scariest thing that we're going to look for. Now, I'm going to get a little bit more complicated and dive deeper than anything we talked about so far. If we were having a person coming in like routine 3rd trimester screening, a woman comes into clinic, we do our non-stress test in order to evaluate whether or not she has kind of a safe and healthy fetus, essentially. The reason we're doing that non-stress test is to evaluate whether or not we might need to emergently deliver that baby. We don't want to necessarily just guess at when we need to deliver a baby or guess at when the baby's in danger. And so the non-stress test is our first step. What do we follow the non-stress test up with? If the non-stress test fails, if it's not reactive and we've woken up the baby and that's not the reason anymore, what are we going to do next after the non-stress test to evaluate fetal well-being? Ooh, lots of really good answers.
Nice.
So I'm seeing a lot of people say BPP, which is biophysical profile. And that is an ultrasound that you will do of the uterus and of the baby to look for a variety of things, including the baby moving around, attempting to breathe, and the fact that they have enough amniotic fluid. And that is correct. That is the answer nowadays. But there's also something called a contraction stress test, where you can supply oxytocin to the woman to give her a contraction. And then you can look at this fetal heart rate and see if that contraction precipitates a deceleration. So by giving oxytocin, you can literally view a deceleration because you can't see the decelerations unless she's contracting. And if she's coming into your clinic for an antenatal checkup, she's probably not experiencing regular contractions to allow you to see that. Now, the contraction stress test is a little bit dangerous because if you give oxytocin to a woman who's at 33 weeks, I wouldn't be surprised to see that she goes into labor at that point. And so we don't like to do that test anymore, and we've replaced it with biophysical profile. But when you see contraction stress test as an answer on the exam, it's very unlikely to be the correct answer, but it's in there for UWorld and for the shelf exams and for step 2 CK. That was historically the thing that we would do following the non-stress test. So we could literally measure a late deceleration in clinic. We could assess that there is uteroplacental insufficiency. We just need a contraction to see it. That's why we're mainly looking for it during labor, because there's already contractions there. All right. Anything to add to that, Sam?
No.
Cool. All right. Let's go ahead and move forward. So everybody take a look at this one and take a look at this very obvious change that we're seeing with the fetal heart rate that I'm just going to highlight for us right here. I'm going to ask, what do people think we're looking at in this case? What's our diagnosis here? All right, seeing a couple good answers. I'll give you guys a couple more seconds to answer here. All right, I got several people saying variable decelerations, and indeed that's what it is. We have a variable deceleration here, and there are two reasons that these are variable. Number one, if we're looking at the actual contractions that we're seeing here, the contractions don't seem to perfectly line up with the decelerations. Now, these seem to line up right here, but this deceleration doesn't really line up with the contraction. It's right in between two different contractions. So there is a variable relationship between deceleration and contraction. But the other way to notice that we're looking at a variable deceleration is the relatively sharp shape and amplitude that we're seeing here, where we reach the nadir of the deceleration within 30 seconds of its initiation. And Sam's analogy here was as though you saw the baby's head being squeezed by the nutcracker effect of that V shape that we get there, which I'm not going to forget anytime soon. So hopefully you guys won't forget anytime soon either. All right, so let's take a look at why we would see this. Everybody got this answer right that wrote in, so thank you guys. Why would we see variable decelerations? What is the most common mechanistic cause of these? All right, cool, excellent, nice. Great job, guys. Lots of answers saying cord compression. So yeah, usually we're looking at umbilical cord compression. And remember, we're going to pay more attention to these variable decelerations if more than half of the contractions yield variable decelerations, more or less, or basically if we're seeing a greater ratio than 50% between those guys. So we do not want to see a lot of variable decelerations, but we're okay with seeing some of them. All right, so Sam, I'll kick it off to you for another tracing example here.
All right, so this is an interesting one. I actually had the head of my clerkship at ObGyn show me this, and I think that this was super high yield, and I think that some of the books actually don't mention this. So who here can tell me this characteristic pattern that you see on the fetal heart tracing? Excellent, so I'm starting to see already that was quick. Matthew So, sinusoidal. Wayne Broth, sinusoidal. Courtney Wood, sinusoidal. Excellent job. So this is a sinusoidal pattern in a fetal heart tracing. So now to take it to the next step, what is that really concerning for with respect to the mother? Okay, Matthew So, I'm seeing anemia. Courtney, anemia question mark. We'll talk about it in a second. Anybody else? So sinusoidal heart tracings are concerning for blood loss anemia. That's correct. And in the context of the mother with respect to the vignette, if she's tachycardic abnormally, she could be a sign of hypovolemic shock and blood loss occurring from somewhere. I actually had on my rotations a woman that went into uterine rupture and was bleeding intraperitoneal space, and it was causing a sinusoidal pattern on fetal heart tracing. It was really remarkable. The baby was at 34 weeks. So that was a classic example of massive blood loss that was occurring, and you could see this characteristic sinusoidal pattern. Always be on the lookout for this on step 2. I think this is very high yield and not featured as much in the text and also on the question banks.
I'll pivot from that and say, when we're looking at that particular case, a woman who's experiencing uterine rupture, what would be the most common risk factor for the development of uterine rupture, especially today in the US? Anybody got any idea among our students to chat?
Very high yield question.
Yeah, they love to ask this one.
Yeah.
Some pretty wild diagrams in your world too. This one as well. All right, so I see a couple good answers here. Prior cesarean section. It turns out that cesarean section leaves scar tissue, and scar tissue is not as strong as the uterine muscle. And so if the uterine muscle is contracting in a circumferential manner and it pulls on that scar tissue, that can potentially lead to rupture of that scar tissue and uterine rupture overall. So previous cesarean section increases the risk of future uterine rupture, which is one of the reasons that a good indicator or a good indication for cesarean section is past C-section. If we allow a woman to go through regular contractions during labor, there's an increased risk that that uterus could rupture if she's had a prior C-section. Now, you could, of course, do a vaginal birth after cesarean. VBAC is definitely something that's allowed. But as far as what is typically done, we generally are going to follow one cesarean section with another because that scar tissue has created a location of lower integrity than the rest of the uterine wall. All right. Anything to add here? Any other questions to toss their way, Sam?
No, that was it. Thank you.
All right, cool. In that case, then we're going to kind of start wrapping up our conversation this evening. We're kind of out of high yield vignettes to share with you guys. We're going to quickly tell you a little bit more about med school tutors and ourselves, but then we're going to stick around to answer any questions that anybody might have about fetal heart tracings or potentially anything related to studying for the OBGYN shelf or Step 2 CK in the OBGYN realm. So please, if you have any questions, feel free to start typing them into chat as I kind of walk through med school tutors and kind of how we usually operate with students that we're working with. So just to reiterate what we had said at the top of our session here, med school tutors is a one-to-one tutoring company that pairs mentors that have gone through the process of applying to medical school, getting into medical school, doing really well on board exams, and in many cases, applying to and matching in competitive residencies with students like yourself who are in the middle of the process. Generally speaking, we work with students to prepare for standardized exams, shelf exams, step 1, but also coursework exams, also board exams once you get into residency. And in addition to that, we also do general career counseling. You'll be paired with a mentor that is in your same field of interest and kind of helps to apply to residency or generate a game plan for the rest of your medical school career to land the position that you're looking for in the future. When we're working with students, we usually meet with them regularly to walk through key material that they'll see on their exams, whether it's step 1 or a shelf exam or step 2. We put together study schedules for students. We kind of give indications of homework assignments and what you should plan to do to succeed on your exams as best as you possibly can. We also communicate regularly with our students in between our sessions that we're holding with them. So I'll regularly have text conversations with my students, occasionally talk with them on the phone. And then even after I'm done working with students, I'll typically tend to kind of keep in touch with them for months and sometimes years to come. This time of year is awesome because I get a lot of cool text messages from people who are matching into residencies, which is always kind of nice. So if you're potentially interested in finding somebody to kind of pair up with to act as a mentor to carry you through the rest of what you need to do for medical school or applying to residency, or probably not in this particular audience, but getting into medical school, you guys are likely in it if you're talking about fetal heart tracings, anything related to medical education, we really like to dive into. And so feel free to reach out to us if you have any particular interest in being tutored by one of our excellent tutors and being mentored by one of our excellent mentors. That being said, if you're not ready to really make the jump into that, we do one-time strategic planning sessions with students where we meet with a student and work with them for an hour just to kind of give them a game plan for preparing for step 1, preparing for step 2, et cetera, et cetera. And of course, also we help to generally prepare students for applications and residency, fellowship, that type of thing. So whether you're looking for a long-term, short-term relationship, you're kind of like looking for somebody to kind of guide you through a bumpy part of medical school, feel free to reach out and contact us. I'll leave our contact information up here. You can call us, email us, or go to our website. In the meantime, though, before we wrap up for this evening, we're going to end up answering any questions you guys might have. I'll also mention before you guys dip out, please try to answer our survey. It takes like 20 seconds to answer, less than it takes to answer a single question in UWorld. It should be up towards the top of the chat box if that's getting kind of cluttered at this point. So please give us some feedback in terms of what we can improve for future discussions like this, maybe some future targeted topics like we did with fetal heart tracings this evening. All right. So Sam, do you see anything in here? Any particular questions anybody have sent our way so far?
Nothing yet. Let's see. Still waiting.
It's okay if you guys don't have too many particular questions for us this evening. This is a very targeted lecture on one specific topic, but if anything comes to mind, we'll give you another couple seconds to maybe type something into the chat box if you have any particular questions.
I think in the meantime, while we wait for some good questions, always just look in with respect to step 2 at the whole clinical vignette. Look at the risk factors of each patient and look at the patient's vitals. It's really important on step 2 CK. They really want you to look at the clinical context of the patient. Okay, now we have some questions coming in. Let's see. Hold on one sec.
I'll go ahead and jump in while we're reading a couple questions that popped in here. In particular, one of the things that I recommend to the students I work with, and a lot of other tutors recommend to their students as well, is that you should try to identify the pathology, try to figure out the diagnosis based on the vignette, and then use the image that's supplied in step 2 CK or shelf exams to amplify the answer that you're already looking for. Now, in some cases, that's not totally possible. It is very likely that if you have a cardiac auscultation question, that you probably do have to listen to the audio file in order to like select exactly what pathology you're looking for. But there is a possibility that even in these fetal heart tracing questions, you can probably get a general sense of what kind of scenario the patient's in, what their diagnosis might be, even before you look at the image. And so if you already have a diagnosis in mind and you can confirm that diagnosis with the findings on the image, it's much easier than attempting to read the image plainly from top to bottom, because sometimes it's difficult to find stuff on there, as we demonstrated with our early deceleration question. Sometimes it's not immediately obvious. So if you already know that you're looking at a woman who's in routine labor and is totally healthy, and they give you the early deceleration question, it should be a lot easier than a woman who's coming in with like abdominal pain and low blood pressure or something like that, which presumptively would not have an early decel in that case if there are a lot of other pathologies happening. Anything you see in here, Sam, you want to answer?
So I think Matthew was asking about where do I look for fetal heart tracings and how can I learn them more? So I think a combination of using UWorld. UWorld has some, also some of the other bigger books that I think Case Files has some excellent fetal heart tracings, and also UWise as well, the other question bank. I think those are some good ones. Having this approach that we spoke about in this lecture in terms of looking at the peak of the contraction and looking at when the actual deceleration begins, for example, or looking at the relation of the contraction when the actual deceleration is happening with respect to sometimes like variable, how there's no correlation. That's how you're going to really crush these questions and really get through them very quickly and know what are some of the common causes of each deceleration. For example, like the early, late, and bradycardia ones that we went over. Anything else you think, Joe?
No, just to amplify that, UWorld is the best question set tool that you can use for shelf exams and for Step 2 CK. And the material they have in there more than adequately covers everything that you could possibly see when it comes to fetal heart tracings on the real exam. And so using those as a portion of a thorough preparation for the shelf exam will naturally enfold the kind of stuff that you need to know in order to really master the fetal heart tracings. UWise is the secondary question bank, by the way, that medical schools often give you a subscription to as you're working on the rotation. The combination of those two sets of questions gives you lots of stuff to work on as you're preparing for the shelf exam. For Step 2 CK preparation in particular, probably don't need to do all of UWise again. I'd focus on UWorld if that's the case. All right, so I think we've kind of answered all the questions that have potentially come our way this evening. So I'll go ahead and say thank you guys for coming and listening to us and interacting with us. We really appreciate the feedback you guys provide. Sam, any last words you want to share with them before we wrap up this evening?
No, I just wanted to thank everyone. Thank you, Joe, as well. I wish you all the best of luck with your future endeavors at whatever stage you are in medical school. And we're always here for you. So thank you all for your time.
Yeah, echoing that, thank you so much for showing up and listening to us for an hour this evening. And we hope to see you in future webinars. So feel free to pop back in and answer some more of our questions. Otherwise, we wish you the best of luck on the exams that you're taking. So good luck on the shelf exam for OBGYN, good luck on Step 2 CK, and good luck on the rest of your clinical exams this year. So we'll be signing out for now, but we'll look forward to talking to you guys again soon.